Hello, everyone. Welcome to our webinar where we will be reviewing updates in pediatric ambulatory anesthesia led by Dr. Michelle Harvey. I am Sam Saeed, an associate professor of clinical anesthesiology at Children's Hospital Los Angeles, Keck School of Medicine at USC, and chair the ambulatory pediatric anesthesia committee with the SAMBA. I also chair the pediatric liver and intestinal transplant group with the Society of Pediatric Anesthesia, SPA. And I am expert panelist on the committee for airway algorithm with the American Society of Anesthesiologists. For those of you who are not a SAMBA members, please consider joining the society as it offers many benefits to the members. And please visit our website. It's www.sambahq.org to see the benefits of membership. A few quick housekeeping notes before we get today started with our presentation. Please note that this webinar is listen-only mode. In the upper right side of your computer screen, you will see a GoToWebinar control panel. Through this control panel, attendees will have the ability to contact our staff via chat and question boxes. We will have time for QA at the end of the presentation, but please submit your questions throughout so that we can prepare to the answer. At this time, I would like to introduce tonight's speaker. As you already know, our speaker is Dr. Michelle Harvey. Dr. Harvey is a pediatric anesthesiologist at the University of California, Los Angeles. She attended Pomona College in Claremont, California, then went to medical school at University of Chicago Pritzker School of Medicine. She did her residency in anesthesiology at UCLA and fellowship in pediatric anesthesiology at Children's Hospital, Los Angeles, then returned to UCLA as faculty. She is Associate Program Director for the Pediatric Anesthesiology Fellowship. She is also the Assistant Medical Director of the Westwood Ambulatory Surgery Center, where she has cultivated an interest in pediatric ambulatory anesthesia. I hand it over to Dr. Harvey for her presentation.
Wonderful. Thank you so much, Sam, and thank you all of everyone for listening in. As Dr. Saeed said, I'll be talking about updates in pediatric ambulatory anesthesia. I have no disclosures. I'll be discussing three major topics from the literature with updates from the last couple years, mostly focusing from late 2018 to 2020. There are many interesting developments, but today I'll focus on updates regarding caudal epidurals, anesthesia for tonsillectomies, and neurodevelopmental effects of anesthetics. So let's get started with updates in the literature regarding caudal epidurals. I'll touch on two subtopics: the safety of caudals in patients undergoing hypospadias repair and adjuvants to prolong the duration of caudal analgesia. So what is known about caudal blocks and hypospadias repair? We know that caudal blocks are safe and effective. Complication rates, as reported by the Pediatric Regional Anesthesia Network, PRAN, are very low for caudals. Hypospadias repair is known to be a painful procedure, with caudal analgesia being superior to penile block or systemic analgesics. Clustered around 2016 to 2017 and some from before that, there were several studies reporting a possible increase in postoperative surgical complications in patients receiving caudal blocks. These complications included fistula formation, wound dehiscence, diverticula, and urinary retention. The proposed but still theoretical mechanism for the increase in surgical complications with caudals is that sympathectomy leads to engorgement, which leads to vasodilation, venous pooling, and tissue edema. But others argue that the engorgement seen with caudal analgesia is a physiologic process that doesn't lead to edema, and that increased risk with caudal is, quote, biologically implausible. So definitely controversy in the literature. After many retrospective studies and a few randomized control trials several years ago, 3 meta-analyses were published in 2019, combining the data from many of these studies to look at overall complication rates across studies. So let's take a look at those meta-analyses. In this meta-analysis from 2018, there were 9 studies, including over 2,000 patients that were analyzed. All were retrospective studies, except for one randomized control trial. They compared postoperative complication rates between patients receiving a caudal and those receiving any other analgesia. There was an increase in post-op surgical complications in the caudal group with an odds ratio of 2.32. When the proximal hypospadias alone was looked at, cases alone were looked at, the odds ratio was higher, 3.55. For distal hypospadias, the odds ratio was 1.31 with a lower limit of the 95% confidence interval below 1. So since this data is mostly retrospective, it is possible that there was some selection bias toward doing a caudal for proximal hypospadias cases, which are more complicated, bigger cases, and proximal repairs were the source of the increase in complications. In another meta-analysis, also from 2019, observational studies were analyzed separately from the randomized control trials. So in the observational studies, caudal blocks were not associated with complications with an odds ratio of about 1.8. And when only distal hypospadias was analyzed, the odds ratio was 1.02. So then for the randomized control trials, once